Hi, welcome to the NEET PG Core Revision series in Pharmacology, where I will be taking up the most important topics for the upcoming NEET PG examination. So today I'm going to talk about anti-arrhythmic drugs. So in the anti-arrhythmic drugs, we have these classes or classification according to the Vaughan Williams classification. Now here what we have to know is that we have 4 classes and the 5th one is the miscellaneous drugs. So we are going to do class wise what are these drugs, what are their major actions and where they are used. So first we are going to start with the first class, which are your sodium channel blockers. They are further subclassified into class 1A, 1B, 1C. And why is that? Because of the action on the potassium channels. So first one, 1A, which has quinidine, procainamide in it. These are the drugs which are going to block the potassium channels as well. So they are potassium channel blockers also. Class 1B, lignocaine, phenytoin, mexiletine, they are going to cause opening of the potassium channel. So these are potassium channel. Then 1C, enconite, flecainide, propafenone and moixazine, they have no effect on potassium channels, right? So where are they used? So the first group 1A, which is potassium channel blockers, so these are used in supraventricular tachycardia and ventricular tachycardia. But remember, the problem with first A group of drugs is because they are potassium channel blockers, so they have a tendency to cause arrhythmia, which is torsades de pointis. Then the second one, which is lignocaine, especially as a potassium channel opener and sodium channel blocker. This is used for VTs, only the ventricular tachycardia. That is the main use. Remember, lignocaine is especially preferred in digoxin induced ventricular tachycardia. 1C, see 1C drugs, the important thing to know about them, these have a arrhythmogenic potential also in them. So they are arrhythmogenic also. Arrhythmogenic also. Right? So they have potentiate one kind of, they are treating one kind of arrhythmias and they are having another kind of arrhythmias here. So here the important thing, where are they used? So this is used for treatment of SVT. This is for VT and in the Wolff-Parkinson-White syndrome, where there is an aberrant pathway. Apart from the normal pathway, there is another pathway also as such. So these drugs are contraindicated in case of myocardial infarction because these are arrhythmogenic. So contraindicated in case of myocardial infarction. Moving on to the second group, which are your beta blockers. So all the beta blockers except sotalol, they belong to this group. So we have propranolol, esmolol, right? We have metoprolol. These are the beta blockers. Esmolol is a shortest acting blocker. Shortest acting beta blocker. So how they work? Beta blockers are going to block the beta 1 receptors. So therefore, they are going to decrease the conduction. Decrease the conduction via the AV node. Also, they are going to block the, or they are going to, you can say, the beginning of the, the point, which is the SA node. So they block the SA node as such. So SA node, they are going to block. Number 2, AV node, they are going to block. So what are they going to do? Mainly are, again, where is it more essential is in cases of supraventricular tachycardia. Why? Because they are going to decrease the traveling of the impulses from the atria to the ventricle, because you know the ventricle tachycardia fibrillation is the most dangerous. So they decrease the conduction of the impulses from the atrium to the ventricle. So therefore they are used for rate control. We call them as, they are used for rate control. But then again they are contraindicated in case a patient has asthma. There we cannot use them. So one, they are used in this. Number two, they are used in other types of arrhythmias which is because of the catecholamine excess. So for example, in case of pheochromocytoma, thyrotoxicosis, right? So all these predispose to increase in the catecholamine level, and therefore that potentiates the arrhythmia. So arrhythmias, because of this, we use beta blockers. You know, there's the drug of choice for thyrotoxicosis and pheochromocytoma. We first use the alpha blocker followed by a beta blocker. Then the third group are your potassium channel blockers. So in the potassium channel blockers, we have ibutylide, dofetilide, amiodarone. Then we have dronedarone, sotalol, and the newer drugs like vernaculant, we have azimilide and tedisamil. Remember here, one of the most important drug is amiodarone. Now, amiodarone, dronedarone, everything is same. Just the difference is amiodarone contains iodine, while dronedarone does not contain iodine. That's why the adverse effect of the action on the thyroid levels, you know, that is not seen with dronedarone. Then sotalol, it is a beta blocker, but it has a higher tendency to block the potassium channels as well. So sotalol, it has class 2 and class 3 effects. Predominantly, it's a class 3 effect. Amiodarone, apart from having the class 3 effect, it also has class 1, class 2 and class 4 effects, right? Now, important thing is, because it's a potassium, any potassium channel blocker, just as we did with class 1A drugs, they have a tendency to cause a special type of arrhythmia which is dangerous. They can cause torsades de pointis. It was seen with class 1A as well. Alright, moving on to the important uses. Now, amiodarone is one of the most commonly used drugs, right? So, amiodarone, they can be used in all types of arrhythmias, especially the ventricular arrhythmias, except torsades de pointis, right? That is very important for this. So, in the ventricular arrhythmias and the others, but it should not be torsades de pointis. Then the drugs like ibutylide, dofetilide, they are used to control the rhythm in atrial fibrillation. For the rate control, we need drugs which decrease the conduction of the impulses from the atria to the ventricle, but also the atria needs to get back into its rhythm also, normal rhythm. So to control that rhythm, we have drugs like ibutylide and dofetilide. Then we have sotalol, that can be used in cases of polymorphic ventricular tachycardia. Next, the fourth group, we have the calcium channel blockers. So, in the calcium channel blockers, we have verapamil, and we have diltiazem. Again, what they are going to do? They are going to block the SA node and the AV node. Never give calcium channel blockers along with beta blockers. Similar action, so they are going to further depress both of these. So they are contraindicated with beta blockers. So where they are given? They are given for maintenance as a maintenance therapy in PSVT. So once the PSVT has been controlled, to prevent further attack, we give CCBs. Oral CCBs can be given in maintenance therapy of PSVT. If beta blockers are contraindicated, especially the condition is asthma. If the patient also has asthma, then we cannot give beta blockers. So instead of giving beta blockers, we give calcium channel blockers. Now, interestingly, there's a newer calcium channel blocker which is called as etripamil. Important or interesting is that it is available as a nasal spray. So you can spray it when the patient develops paroxysmal supraventricular tachycardia. Otherwise, patient had to rush to the hospital and then you give IV adenosine. But here they can be given in PSVT acute treatment as well. In the miscellaneous group, we have digoxin, then we have adenosine, magnesium sulphate and atropine. Now let's see this. Now digoxin, what it does is, it is because it has a vagomimetic effect on the AV node, which means it causes conduction delay. Conduction delay, right, at the point of AV node. So where do you think it is used? It is used in case of atrial fibrillation in patients of CHF, right? Atrial fibrillation in patients of CHF. Then we have adenosine. Adenosine will activate A1 receptors which are present in the AV node. Now these receptors, actually these are GI kind of receptors which decrease the cyclic AMP, right, and they decrease the calcium influx, but they increase the potassium efflux as well. So they are depressing the system again. So this is a drug of choice in case of PSVT. Magnesium sulphate, they are just going to stabilize the myocardial membrane, right? So they stabilize the myocardial contractility. So they just work opposite to that of calcium. So therefore, magnesium sulphate is a drug of choice in case of torsades de pointes. Acute attack of torsades de pointes, magnesium sulphate is used. Atropine. Now, atropine is an anti-muscarinic agent, right? Anti-muscarinic drug which causes the M2 block. Therefore, it depresses the, it will increase the heart activity, because M2 or parasympathomimetic, they depress the heart activities. So atropine is going to increase them. So where can it be used? It is used in case of bradycardia, and it can be used in case of AV block. So these are the miscellaneous antiarrhythmics that is being used. Now let's do a question from the previous year. A patient with a history of myocardial infarction and ventricular arrhythmias has been on an antiarrhythmic therapy for several months. He now presents with fatigue, dyspnea, weight gain and pulmonary fibrosis. Which drug is most likely responsible for these effects? Amiodarone, atenolol, aspirin, spironolactone. So remember, there is fatigue, there is dyspnea, there is weight gain, there is pulmonary fibrosis. So out of them, we know that aspirin and spironolactone, we don't use them in case of arrhythmia. So that is ruled out. Now we are left with amiodarone and we are left with atenolol. So pulmonary fibrosis and weight gain and all these things, I don't see it with a beta blocker. But we know that pulmonary fibrosis is a hallmark of, it can be seen with long-term therapy with amiodarone. So amiodarone is the correct answer. Now, what are the important toxicity signs of amiodarone? So remember that there is 1T, 2P, 2L and 2C, right? So TPLC, 1, 2, 2, 2, everything rest is 2. So 1T stands for thyroid dysfunction. It can cause thyroid dysfunction. Then 2P stands for pigmentation. One is pigmentation, which is blue man syndrome. It is called as blue man syndrome, and the other is peripheral neuropathy. So here you can see this kind of a blue man syndrome that is seen with amiodarone. 2L, one is for liver and the other is for lung. So it is hepatotoxic. It causes liver toxicity and it causes lung fibrosis. Are we talking about pulmonary fibrosis? 2C, it causes corneal deposits, just like we see here, corneal deposits, and it can cause cardiac depression as well. Cardiac depression and corneal deposits. Now, apart from amiodarone, are there other drugs which can cause pulmonary fibrosis? Yes. And how to remember those drugs? We have a mnemonic called as BBC Ban Me. So let's see what are these drugs for us. So 1B is bleomycin. Then we have busulfan. C stands for cyclophosphamide. B stands for bromocriptine. A stands for amiodarone. N stands for nitrofurantoin and M stands for methotrexate. So BBC Ban Me is a mnemonic for all the drugs that are important for you to know which are causing pulmonary fibrosis. Alright, so let's quickly glance through what are the important arrhythmias and what is the treatment that you should know about them. So bradycardia, AV block, I already told you, for these two we give atropine, which is an anti-muscarinic drug. Very, very important to know. PSVT, paroxysmal supraventricular tachycardia. So there is a sudden episode of supraventricular tachycardia which has occurred. So what is the drug of choice here? The drug of choice is adenosine. We give IV bolus. It's a very short acting drug, immediately produces effect, and onset is also duration is also very, very short. So IV bolus. So in children, you use 0.1 milligrams per kg, and in adults, what do? You use 6 milligrams. That is the dose. Now, adenosine is contraindicated in case the patient has asthma because it is a bronchoconstrictor. So, therefore, we use CCBs. Parenterally, we use the calcium channel blockers for this, right? So, and also one thing more is that the blood pressure should be normal. Then supraventricular tachycardia, here if we talk about what is the difference in treatment. So, we have to, you can give A, B, C, D regime. What else? Because the main point here is to inhibit the impulse traveling from the above the ventricular to the ventricle. So, we have drugs which we give A, B, C, D in order of preference also. A is adenosine, B is beta blockers, C is calcium channel blocker, and D is digoxin, right? So remember, if there is asthma, then adenosine and beta blocker, they are both contraindicated. Then you will start with CCB as a choice in case of asthma, okay? Digoxin is usually effective in case of, if this is not working, then we go on digoxin. And why are we using? I've already told you that it has a vagomimetic effect on the AV node. All right, moving to the atrial fibrillation. So in the acute phase, we can do cardioversion. For the chronic or maintenance, what do we do? the preferred drug of choice for us is beta blockers. But let's say the patient has asthma, then you cannot give this, then we give calcium channel block. That is very important to understand here. Now, if there is atrial fibrillation with CHF, atrial fibrillation with CHF, then we would prefer to give digoxin. Okay, so we prefer to give digoxin here. Now, ventricular tachycardia. So, what is important in case of ventricular tachycardia for us to know is the drug of choice here, or we prefer rather to give amiodarone. So, we prefer to give amiodarone here. But in case of ventricular tachycardia associated with digoxin, right, there the drug of choice is lignocaine. So, most effective drug here, right. Ventricular fibrillation, here we have to do defibrillation. Okay. Now, what is the important thing to note here is that whenever in this atrial fibrillation, this is to control the rate, the drugs. For rhythm control, we need to give drugs like ibutylide. Right? We've done before that. So, for rhythm control, we can give, for rhythm control, you give ibutylide or dofetilide. So, this was all to control the rate first, because that is the most important thing to do first, that we need to control the rate of impulses, which we don't want to reach the ventricle. Because ventricular fibrillation is the most lethal thing. It can cause death within seconds rather. Now, Wolff-Parkinson-White syndrome, what is the treatment? The best treatment would be you do the ablation of that, a particular region, ablation. But what is the other long-term treatment? We have flecainide. Right? Flecainide is a drug of choice here. Now, torsades D point is acquired congenital. Any case, if there is an acute attack, whether it is acute attack in case of acquired, whether acute attack in case of congenital, your drug should be magnesium sulphate. In congenital, later on, you can give beta blockers. Okay, so beta blockers are preferred in case of congenital, and which do we prefer? Propranolol. Now, in case of catacollar mean-induced arrhythmias like pheochromocytoma, ventricular premature beats, even in thyrotoxicosis, again we will prefer propranolol. Right? So, these are the various anti-arrhythmic drugs and the important points that you should be very, very well versed with.